shook his head hard enough that it broke one of these veins that bridge between the covering of the brain and the brain itself. So if you imagine with me, you have the scalp, which we can all see. Then underneath that is the skull, which is the hard, case all our brains are in. And then underneath that is the dura. And the dura is kind of like a leathery covering of the brain. It protects the brain.
Yeah.
And then just underneath the dura is where this space is.
Excuse me.
Yes?
You think we can take what you're saying so I can explain to our
We don't have
son?
a tape recorder, Mom.
I'll just record it.
Oh,
Sure.
you're recording it.
Okay.
Oh, I'm sorry.
I'm
That's
sorry.
fine.
I just
I'm sorry.
No, don't be
You know,
sorry.
because,
Let's start all over again.
Because we want to explain to our my sons and daughters
I completely
what you're
understand.
saying.
No problem.
Because we can explain to them what you're saying.
Right.
We know, but it's okay. Go ahead.
Not a
Está
problem.
bien, está bien.
Acércate. Acércate.
And
Oh,
so-
well, I want to, okay, but he's
This-
pointing and I want to record what he's pointing to.
Yeah.
And so this space right here is what I was referring to as a subdural hematoma.
Okay.
Now that's just technical speak for a blood clot. Basically,
Yeah.
that's what it is. Now the unique thing about this blood clot, though, is that it's been there for some time, so it's probably liquefied. In fact, that's what happens to blood clots over time.
Oh.
And the reason why it shows up kind of like this dark picture, is because that's likely what it is. It's been there for some time.
Que ha estado ahí por mucho tiempo.
I know.
Now, if you see with me right here, there's a little area that's different. You see that little spot right there?
¿Ves
Yeah.
dónde apuntó?
Sí,
¿Ves
sí.
dónde? Ajá.
That is probably an area where there's some new blood. So acute blood, meaning that it happened in a short period of time. So this is what we call, just for lack of a better term, a mixed density subdural hematoma. And so what it means is that there's old and new blood. The next question becomes, so if we're going to do something about it, what do we do? And that's where we were at. In other words, it sounded like your mom wanted to kind of get some other people involved to talk about options.
Yeah.
And the question to answer really is what you think your dad or your husband would have wanted in this situation. And in this case, it sounds like he's not really able to answer for himself. In other words, I don't think he has capacity.
Right.
And so we have to sort of do some thinking and deciding for him. And that's the reason why I wanted to talk to you.
Okay. So tell us what happens, what the options are, or...
So there's a number of options, and that sort of depends upon...
Oh, here's my husband.
Sure.
Hold on 1 second.
Take 3.
Take 3. We're waiting.
I mean,
These are the people
Hi,
who are
sir.
taking
How are you?
care. This is
nice to meet you.
Dr.
Dr. Braca. Nice to meet you.
Baraka. He's going to talk to us about options and show him the blood.
So this is the CAT
Yeah.
scan.
Yeah.
And this collection right here is what we were kind of
It's
talking
old.
about. It's what we call a subdural hematoma.
Right.
And this radiographically signifies that it's been there for some time.
Yeah.
Now there's little what we call foci, or small areas of new blood, but that's not uncommon to see. Sometimes you can see a little bit of new blood in an area where there's been a bleed. Of course, that's probably how this old blood accumulated, is slowly over time.
Just like a seepage from one of the blood vessels.
Yeah, could be, exactly. And so we were just getting to is sort of the discussion about if there's something to do, what do we do and when? And that's why, it looked like there wanted to be a sort of a family discussion about his disposition. And I think the important thing to think about in this situation is to think about what he would have wanted, given the situation that he can't answer for himself. And so that's where we're at.
Right.
Okay.
And I said, what are our options?
So we could do the following things. We can do nothing. We can watch. Now he's got a favorable neurologic exam. That doesn't mean we don't do anything. That just means that it's a possibility. The second option is surgery, and then what kind of surgery? Well, we can do something small, like what we call burr holes, and then we can do, which is just literally putting holes about the size of my thumbnail into the skull and allowing this to drain. Now, given
So
that,
is this liquid? That's
yeah, likely.
The
So
dark.
it's-
The dark.
the dark
portion,
is,
yeah.
and it's
Likely.
causing some pressure.
If you can see here, it's pushing everything over. It's causing what we call mass effect.
That's That's our parking ticket. It fell out of your pocket.
Oh,
You don't need that.
okay.
So this should have been in the center of his brain.
This line here.
Yeah.
Yep.
Oh, I see.
see
And
how
it's been
kinda pushed
pushed
things
over because of the blood on that side.
Mhm.
Okay.
And the sort of the most extreme of things, in a situation when we have other areas of new blood, is to do something called a craniotomy, where we take part of the bone off, we investigate it, we evacuate this fluid collection, assess whether or not we can put the bone back on, and then go from there. So
Why would you go that route instead of the little burr holes?
So, although the burr holes are nice and convenient and they're smaller in terms of a procedure, they don't address this area here. These small areas of what we call, if you look right here too,
There's
with a
another.
chronic subdural, what happens is you get these areas of what we call septation. And what that means is there are just these little membranes that form that
Yeah.
develop their own vasculature. And they're problematic. In other words, if we just put a burr hole in and irrigate it very aggressively, we
Yeah.
can stir up bleeding that at the time of surgery we don't notice, but that slowly oozes over time. And we can end up back exactly where we are, and the
Right.
eventuality could be a craniotomy. So the reason why I kind of explained it in terms of a spectrum is a lot of times when we see this type of scenario, we default to doing something that's a little more aggressive, only because we don't want to risk being back into a situation where we started, one, or worse.
What's the risk of that procedure with someone his age?
Sure. So with any surgery, there are risks.
Sure.
And the way that we look at it is we weigh risks to benefits. There's a risk to benefit ratio, and the potential risks and the potential benefits. If in general the benefits outweigh the risks, we make a decision together and we move forward. The risks, just to sort of list them, the major things: bleeding. So the scalp bleeding and that kind of thing isn't something we worry about too much. He does take Coumadin, so that thins his blood out. So one of the considerations is making sure that his INR level is appropriate, that it's normal. So we will give him a special medication to see if we could bring that down in a timely fashion, and hold the Coumadin, of course.
Right. Oh,
The other risk is bleeding inside, so bleeding of these septations, like I was describing to you. There's a small chance, it's hard to slap a number on it, but there's a chance that those can bleed, and they're difficult to stop because the membranes are very friable, they break apart very easily, and so they're difficult to control. And what we often find ourselves doing at the time of surgery is chasing them. In other words, you chase them into an area you can't see any longer. And so that's the reason why they're problematic. Now that's a technical consideration for us. It's not something to sort of direct what we do. It's just that it's how they present problems. That's all. The other risk is anytime we make an incision, there's a 1% chance, at least in our hospital, for all comers, old, young, sick, healthy, for a
Infection.
surgical site infection. And we, of course, minimize that risk every step of the way with every possible intervention we have, from perioperative antibiotics to, of course, properly prepping and draping the area. Everyone in the operating room is, of course, sterile. All the instruments are, of course, checked and sterilized. So we minimize that risk as much as possible. And the third thing is neurologic injury. I don't suspect that that there will be major issues. Sometimes, though, what we can run into is, since this has been compressed for some time, and again, I can't slap a number on it, but I can say off the top of my head, probably at least a month that this has been going on, maybe longer, that sometimes when this pressure is relieved, this area here re-expands, and sometimes if it re-expands quickly enough, you can get what we call intraparenchymal hemorrhages, meaning blood can accumulate inside the brain substance itself. Again, what's the number on that? I'm not sure. It's a
Right.
small percentage, but it's not zero, and that's the reason why I bring it up.
Well,
I know.
let's see what we
Now,
think.
with the information I have for you so far, his lab value, so his INR at the outside hospital is 1.7, which is not normal. It's 'cause
What's
he's
the
on
INR?
Coumadin. INR is a measurement of coagulation, the blood coagulation.
Oh.
It's just a number we follow, and we
Okay.
slap the value to it. A normal number is anything below 1.3. So what we'll probably do is give him some special